what you get out of these group things is, you know, meet new people, network, find out what other people are doing. So thanks for sticking with us. Our next speaker is Korey Capozza. She is the Consumer Engagement Director for HealthInsight Utah, which most of us are from. She leads a number of innovative technology-based initiatives to empower patients to improve their own care. And prior to joining HealthInsight, Korey worked as a consumer health advocate in the Utah legislature. She holds a degree in health policy and management from UC Berkeley. Korey.
Thank you. Good morning, everybody. I wanted to start, and I have no disclosures. So,
Point out the disclosure statement.
No one involved in the planning or presentation of this activity has any relevant financial relationship to disclose. And we have no commercial support. But I wanted to start out just by getting a sense for your backgrounds and what you might be interested in. So how many of you come from healthcare delivery? Nobody? Okay. Technology? Aha, okay. You will find touch points with my presentation, so that's great. So the area of this sort of wheel that I'm going to be addressing is consumer engagement or patient engagement, which Dr. Masiras alluded to in his presentation. He mostly talked about the importance of getting patients involved in their care, and what I'm going to talk about is, okay, great, how might you go about doing that, especially with new technology innovations that are coming around to really do that in a new low-cost way. This is a really difficult sort of nut to crack in healthcare. It's very hard to get patients to take charge of their care and to manage, especially a chronic condition, optimally. So there's some exciting progress, I think, being made on patient-centered technology to really assist people with that. So I'll be talking about some of the experiments we did in the Beacon to test some of those things out. So the objectives are to really kind of convey why the patient is paramount in this reconfiguring healthcare system that, you know, is constantly evolving and today changing very rapidly, to convey what that changing role might be, and then to describe some of the interventions that we put in place to really move that patient to the center of the care. Has anyone seen this before? Sarah has. She's seen my presentation.
Well, Mark showed it yesterday.
And he showed it yesterday. Okay, so Americans are fat and they're getting fatter. So in 1994, we were kind of fat. You know, 14 years later is remarkable. So the red is, I think it states where 30% or more of the people are considered obese.
Why did it change so rapidly?
So I think the jury is out on that. There's a lot of theories about, you know, people eating more fast food, two working parents, kids especially exercising less, video games, et cetera. But I don't think anybody truly knows. If you look at this map again in 2012, it's even worse. So this is a massive epidemic that has been continuing over a 20-year period. And Utah's doing a little better than most, but we're getting worse as well. And this actually is not just an issue of vanity. It has profound implications for health and health care, because marching along with this obesity epidemic is an epidemic in chronic disease. As this slide shows, obesity brings along with it a host of problems here: coronary heart disease, you know, gallbladder disease, et cetera, pulmonary disease, stroke, et cetera. But the big one, I think, that we're seeing marching hand in hand with this obesity epidemic is type 2 diabetes, which is the focus of the Beacon program. When we think about these chronic diseases that are exploding along with this obesity epidemic, what's happening is there's also a huge rise in healthcare spending. And Mark probably touched on this yesterday in his presentation, but 80% of the people consume 20% of the healthcare dollars in this country. And 50% of the people are consuming 5% of the healthcare dollars. So it's a subset of people that are really using up our healthcare resources. If we look at that 80%, who are they? They are folks with chronic disease. So if we want to get our costs under control in this country, we need to figure out how to manage chronic disease better. And we've made strides in some areas. In some areas, we're still, I think, really lagging behind. So let's look at diabetes alone, just one chronic disease, which is the focus of this project. We spend $176 billion on direct medical costs for diabetes. This is the 2012 figure. Where does that money go? The top spending category is hospital care, And as many of you probably know, a lot of that hospital care could be averted if diabetes were better managed. But what's happening is it's poorly managed, and then there's these acute episodes and people go to the ER or the hospital to get care. Nursing home care is another big category, and office visits are actually a relatively small sliver. 10% of the spending dollars go to actual office visits. When we drill down into office visits, these are pretty infrequent and pretty minor in the scheme of things. A poorly managed patient with diabetes will see a primary care doc typically 4 times a year for 15 minutes. So in the scheme of things, care delivery is a relatively minor piece of the puzzle. And that's because if a patient with diabetes is seen the recommended number of times, that amounts to 60 minutes per year. 500,000 minutes a year, they're on their own, out in the community, out in their homes with their families, try to manage this disease on their own. But currently, we dedicate very little money, very little attention to those 500,000 minutes that these folks are meant to be doing a host of self-care activities that, in effect, are fairly difficult to pull off. This includes the blood sugar monitoring, the pricking, the testing, diet change, physical activity, taking all your meds on time, checking your feet, the eye exams, etc. The host of these activities is called self-care, and it's almost shocking how little attention we pay to making sure that those self-care tasks are occurring and that patients are managing themselves well on their own. How many people here have tried to lose weight? Yay, okay, a couple. How many of you succeeded and kept it off? Okay, so you people are not normal. That is not typical.
These PMI people are very
Yeah, that's right. It's like a very high achieving crowd. 90% of people gain it back, and it's a similar statistic for smokers. It's really difficult to succeed with health behavior change, and as a starting point, we need to acknowledge that. Self-care is really hard, as this cartoon suggests. And oftentimes with a disease like diabetes, this profound behavior change that needs to occur to really self-manage optimally is a super big drag. It's actually not fun to prick your hand, several times a day and check your blood sugar. It's kind of a grind. And so when we look out at the literature, statistically, only about 16% of patients with diabetes are doing all of these things optimally. That's 16%. And these things, the things that were on this last slide, are the activities that will keep people well. So we're really failing, I think, in the current paradigm with how we treat this disease by focusing on the brief encounter in the clinical setting and not focusing on empowering patients, training patients to really deal with this condition beyond the clinic setting. So what we did in the Beacon program was we said, okay, clearly there's a need here. How can we leverage technology to help patients succeed outside of the physician office setting? If we're really going to address type 2 diabetes measures in a very short time period, we need to focus a lot of attention outside of that clinic setting where the patient is on their own. So we took on a number of initiatives. We had about 7 going during the Beacon program. I'm going to focus on 2 today, or 2 really focused on direct patient self-management support. One is a cell phone-based program which uses 2-way text messaging for coaching, education, and support. How many folks here have a health app on their phone? 1. That counts. That counts, yeah. 1 there, okay. So this is an area that's been really taking off, and there's sort of variable quality in the types of health apps that are available. This program was not an app. It was a basic SMS shortcode program that was driven by a computer algorithm to mimic the sort of communication that a patient might have with a care manager. But an interesting new innovation that we tried out, both in a randomized control trial setting as well as in a general quality improvement setting. So we have data on about 450 patients that tried this program, and I'll talk about that in a minute. The second program was really directed at helping patients deal with any chronic disease, not just diabetes. And we were particularly interested in that kind of intervention because 50% of people with diabetes have another chronic disease. So if you look just at diabetes, you're not sort of addressing the whole problem. So we tried out the Stanford Chronic Disease Self-Management Program, which is typically an in-person, peer-to-peer, 6-week support program the technology innovation we looked at was a online version where you're working with sort of virtual peers and asking, can we see the same benefits that you would see with a person-to-person training and support group? So the first program, the Utah Diabetes Mobile Health Pilot, we had research approval for this, looked at the Care for Life program. We chose this program because we knew that basically everybody has a cell phone with them at all times. And that's true across age groups and demographics at this point. Even your grandmother probably has a cell phone in her purse. What that means for these type of programs is you can reach people in real time when they're making health decisions because they happen to have it in their pocket, send them a text, and you can get them when they're sort of in the process of making a health behavior decision. So a lot of promise there. The second piece is that, we know that nurse care managers are very effective. It's been well established. But given the epidemic in diabetes that we see on the horizon, it's not a cost-effective way to really support patients. There's a limit to how many patients those human care managers can actually support. This type of program, it's limitless. It's computer-driven, so you can have a 1 to 2 million ratio as opposed to a 1 to 700 patient ratio. So in terms of bending that cost curve, this was also a really attractive innovation. Any questions on anything so far? Okay. So what does this look like? Essentially, a patient enrolls in this program. They select the type of protocols or messages they want to receive, and these can come in a variety of flavors, sort of. They include blood glucose checking reminders, medication reminders, coaching messages related to health goals, and general diabetes education messages about how to optimally manage the disease. And the important thing about this program that we found was it was totally controlled by the patient, so they could get as many or as few messages as they wanted. They could turn it off at any time, and they really liked that aspect. So they had sort of nothing to lose by getting into it, and it wasn't forced upon them. An interesting part of this particular tool that the technology company that came up with it was interested in testing through our community was to have a sort of fake person behind these messages. So the messages came from this avatar here, Paula. And so I personally thought that this would fall flat because I thought people would find it kind of phony. It's clearly a computer, why pretend it's a person? And I was wrong. People really liked Paula. So the messages would say, hi, John, it's Paula. It's time to check your blood sugar. And then, there'd be a follow-up message. Good job, John. Here are some things you can do to keep up the good work, et cetera. And we actually had a couple of patients who thought Paula was real and called our office asking for Paula, causing a lot of confusion on our phone dashboard. So, it just goes to show, what you may like may not be true for all patients. And it was really interesting to see how they connected with this fake person. If you have teenagers, they text all the time. Grandmothers, not so much. I mean, it's a pretty clear curve in terms of usage. When we signed up people for this program, we found we were mostly getting the older baby boomers and the grandmothers. And so it was hard to get people in the program. This was not something that they were accustomed to doing. 80% of our folks were over age 40. So these were not your young whippersnappers. And interestingly, even with this older population, we found people were really able to figure it out and use it pretty easily. Here's the texting by age group slide. Up on the left, there's your teenagers, and then as you move out towards 65, it just plummets. I think this is changing. I think the fastest growing group of texters and app users and so on is actually the over 50 set. But right now, in this point of time, it's still a relatively new technology for people, and they need quite a bit of help, is what we discovered. We did a telephone survey targeting our invited patients for this program, and we found that their cell phone usage, their computer access, and their familiarity with a web browser was pretty low, and it was well below the national average. 62% said they could use a web browser. That's a lot of people who can't use a web browser. And at times, enrolling these folks in the program was painstaking. I had an hour and 15-minute conversation with a fellow on the phone, trying to direct him to the place where you put in a web address. It kept going into like the Bing window, and it was really eye-opening, I think, how the technology barriers that exist for a lot of people.
Was that survey in the
This was just in Utah. Yeah. These are folks with poorly controlled diabetes, so it's a specific population. But I really had no idea that we would find this. So when we actually had people in this program using it for a number of months, we found that they loved it. At exit, we did a survey, and we also did a text message program survey at the midpoint at 90 days. At the midpoint, we found that 94% of the people who responded at that point would recommend this program to another patient with type 2 diabetes. And then we used a validated survey, a more research-appropriate instrument at exit, and we found very high patient satisfaction scores, 27.7 mean out of 32, and it was really across the board. So we were surprised by that, given the age of the patients in this study. We also looked at clinical outcomes, so did their blood sugar improve, essentially. And we did see an overall improvement in the folks that were using this tool compared to the folks that were not, because we set it up as a control trial with a control group. We didn't reach significance on that finding statistically, however, because a huge number of these patients were not coming in for their regular blood sugar tests with their doctor, which was the data point we were using to measure efficacy in the program. And so, with Dr. Masidas's presentation, he talked about, the need to get these folks in regularly. They're not coming in regularly, and for a variety of reasons. Maybe they're not ready to deal with their condition. Maybe their physician office isn't bringing them in at a regular interval. But these folks are not having touch points with the medical system in the way that they should, is what we found. However, we did have some statistically significant findings, and we found that for some folks, they showed remarkable improvement. And things that predicted that included being a woman. They did much better than the men. Younger age, which is not surprising. Folks that are, I think, more familiar with this technology did better. And then people with high blood sugar at baseline. So the folks that were the most poorly controlled had the most room to improve, and we saw they did improve the most. So some interesting information to perhaps target something like this to a more specific population in the future. Just quickly, some lessons learned. I think one is perhaps a rather obvious one, but patients are unique individuals at different places with their self-management goals. And so this one technology tool was not going to solve the problem for everybody, but it did for some. And so we need a variety of approaches to really engage patients. And then second of all, technology is not the silver bullet. It's the combination of physician support, coaching, a variety of things. And also we provided a fair amount of human assistance with the sign up in this program and the ongoing training around it. So there's sort of an idea out there among the sort of health technology crowd that you can just kind of throw this stuff out there and everyone's going to use it and improve, and it's just that easy, bing, bada, boom. And it's not. People need a lot of support in familiarizing themselves with these kind of tools and in getting enrolled in them in the first place and figuring out how they work is what we found. And then just tracking, so sort of just tracking your weight or your blood sugar. I don't think that's enough. I actually think the coaching and the support is a key aspect of this. That feedback that you're doing better, just knowing what your data is, I don't think is quite enough. When we talked to people, they liked Paula. They liked that she was looking out for them and offering encouragement and so on. So that coaching, that human relationship or computerized human relationship is also a key piece.
Kelly's my dietitian, but she's also somebody I can talk to and a very close friend. And Dr. Bernanke is my doctor at the St. Mark's Clinic. I can talk to them whenever I need to talk to them. If I feel something's going wrong or something isn't right, and that I can call and talk to Kelly about it. Kelly and Dr. Bernanke have just been there right working with me, making sure I stay right on level and I'm in sync with everything that's going on. We've talked about several things. We've talked about my diabetes situation, how to control my diabetes and bring it under control so that I am able to function normally without being a zombie most of the time, or living in fear that that diabetic coma is going to be there. If they didn't care about me, and if the doctor and Kelly didn't care about me, then I probably wouldn't care about myself either. I would just go on along just trying to do my own little patch-up job instead of doing it the organized way like the doctor and Kelly have both showed me how to do. Well, the next time I came in to see Dr. Bernanke at the St. Mark's Clinic, I had noticed that my blood sugars had started to lower themselves. And also, I was starting to lose the weight, which I was happy. I thought, whoo, I'm losing weight. Good. That's great for me.
She talked about this Care for Life program being sort of a friend to her and somebody who was looking out for her. So she was one of the patients that really, I think, connected emotionally with this computer program, and it's interesting to hear her talk about it, but take my word for it. Yeah, and she recruited her neighbor to use it. She said that she would get these messages from Paula and forward them to her friends. So, yeah.
Did you ever take the next step and back Paula up with somebody? You said you were getting calls to the switchboard. You know, take that persona one step further and have
Yeah.
like connect them to a nurse or somebody
Yeah.
who can help them to
You know,
bring them to life.
yeah, and that's interesting. That's how some other groups have implemented this program, with kind of a human back-end support. We didn't do that. We were sort of interested in this in its most sort of technology, patient-centered form. But I think that's a direction we were thinking about going in the next iteration of this. So it's a good point. Yeah, and have her tricked out like Paula. And
It's like flow in the insurance commercial.
That's right, yeah. Yeah, I like that.
And the human aspect is actually really important, and studies show, like, you know, your health plan might have care managers that call you and tell you what to do, but they found that that doesn't really work because they don't have that relationship, you know, kind of one-on-one relationship. Very important to have that.
Yeah, I mean, I will say that in the actual study part of that program, I think we had 159 patients that we were tracking. And by the end of it, I knew them all by name. I knew their story. You know, so even without the care management, there was a human piece of this where we were supporting these people. And you really get to know them and the peculiarities of how they use the tool. There was one fellow out on the west side, and he had a love-hate relationship with the tool. Because somehow he managed to put a signature on his text messages. I've never heard of this, but you can actually put you know how people put quotes at the end of their emails or whatever? Well, he had one of these going on his text messages that said it was a quote from somebody or something, and it was screwing up the computer algorithm because it didn't recognize his message. He was just supposed to text in a number for his blood sugar, and it would come back and say, wrong or error, you know, you've entered this incorrectly. And he would get so upset because he said, no, I'm doing it correctly. And he would call and he'd be like, this, you know, Paula's being mean to me and this and that. And finally we figured out by going into the system that he had this sort of tag on his text. So it's just interesting kind of in the wild how this moves with people and how they react to it. So you really do get to know people. Okay, so I'm going to shift over to our second program here, which is the Stanford Chronic Disease Self-Management Program, which has been around for 20 years. Unlike Care for Life, this is a very established tool. On the Care for Life program, we were one of the first sites in the country to test that program. Along with a group in San Diego, we're just publishing the results, and we're the first two to really try this out in the clinical setting. So very vanguard in that sense. This program was developed, I think in the 90s, 80s or 90s, and has a very established track record of published research showing it works on a number of fronts. Lower costs, fewer hospitalizations, improved outcomes for patients with any chronic disease. So keep in mind, this is not about diabetes, this is about how you approach any chronic disease. Kind of the hallmarks of the program are it's a 6-week training program. It's typically done in person with peers, not with medical professionals. So another interesting element there. The fact that it's not with medical professionals and it's with peers makes this also a very low-cost intervention. And it focuses on common skills related to coping and goal setting and peer support. Surprising that you get these kind of outcomes from that sort of intervention in a way. Core skills that are learned in those 6 weeks: short-term goal setting, problem solving, how to do exercise, fall prevention, dealing with fatigue and pain, medication management, getting on a diet plan, depression management, something that goes hand in hand with diabetes in many cases, decision making, how to know how to kind of tackle decisions related to your health, and stress, a huge one. So these are sort of the things that people take away from this, not sort of how do I test my blood sugar. So as I mentioned before, what we did is we were interested in testing an even lower cost version of this, which is an online program that people sign up for. And then they're matched with peers virtually. And this peer-to-peer workshop occurs in the virtual setting. The program was being offered for free by the National Council on Aging. Actually, it still is. So we took advantage of that to try and get as many Utah patients as we could enrolled during this window of free time. Here's a event that we held in one of our clinics. We've done about 18 of these where we station people out there and we help get them signed up in these 2 programs. This one was a huge success, standing room only, patients out the door waiting to sign up for this program and a variety of other programs offered by community partners. But I think it really speaks to the need out there that patients have for some support outside the clinical setting with managing chronic diseases. Some things we'll be looking to sort of test with this is this as effective as an in-person workshop? Does the convenience of being able to take it online increase completion rates? Can we reach people out in, Summit County? We have patients up there that we're working with. And is the usability, again, adequate for an older, sicker population? As we found with the Care for Life program, your assumptions about people's technology abilities can often be exaggerated. In my case, I thought everybody had a smartphone. Not so much. Cell phones used in that program were extremely basic. So again, we'll be looking at, can people actually use this new online format, or are we a little bit ahead on that? Is the next generation of baby boomers that are aging now that are really going to take these things up? So I think the jury is still out on all of these questions. And then finally, I wanted to just point out a resource that my colleague helped develop over the past year, which is a website around helping patients and consumers deal with end-of-life decisions. This is a very taboo topic, and I think this site is really structured around practical stuff, what to expect, how to do some of these things that you need to do with planning for end-of-life. And I think it's a really great, clean site that really assists people with those kind of questions. So just kind of giving a shout out to it. It's called Leaving Well, and it's really targeted to Utah patients. So I like this slide because I think as we envision where we're going with healthcare, it really is changing from being oriented completely around healthcare providers, physicians, hospitals, and so on. And we're undergoing this massive change, which is really exciting, which is changing the orientation to put really the patient at the center, helping them be the masters of their own care so that they can succeed with their own health goals rather than being sort of passive participants in this journey. And to really get it, I think it requires looking at the world a little differently. And so this is what the globe looks like if you are, sort of south hemisphere centric. And doesn't it look different? And so I think it requires kind of tilting our heads to kind of get a sense for what this is going to look like and where we might be going. So I'll just leave with that thought. I think it's very exciting, and I think the world looks great that way. Look at all that ocean. So any questions for me? Sarah?
I just think, so the work we did with the Care for Life really took it to, were the patients' users, are they interested, and that some people can, some people can't. And within the meaningful use, I'll talk about it a little bit, but, physician offices are going to be expected to have portals where they communicate with patients electronically. And I wonder if there's signs that some little support, like that provider or that person in the office behind virtual support, yield what we think it will. So I'm just curious, any thoughts on that? I mean, do you think that connection to the office, could that be?
For the patient
quickly-
portal?
Yeah, portal and texting, or portal and self-management.
Yeah, I think that'll be part of that. So we're currently undergoing a 2-state study on patient portals, and it's interesting to see that some physician offices have like 60% of their patients using the portal. Other folks, they can't crack 5%. So part of what we'll be looking at is why. Is it the connection to the physician that's so key? If you really love your physician, you want to have ways to be in touch with them, or is it support with the technology? So I think we're still learning about that, but it's a really interesting question. Is it the technology that's the barrier, or is it the use case? They don't see it yet, so it'll be interesting to see. Neat.
I find the patient portal that we use with our family is really valuable for being able to contact our physician,
Yeah,
ask them questions, find out about this result.
yeah. Yeah, I use the U of U one all the time. I think it's great. You do,
Do you feel a personal connection to your physician through that?
Absolutely.
Yeah,
Yeah.
so there's that, combo.
Yeah.
I kind of wonder if our facility is a long-term care facility for people with disabilities, and so these patient portals engaging with patients in meaningful use, we kind of wonder where do we fit in that whole landscape, because
Yeah.
it's really the direct care staff that would understand. They may be the ones that need to be able to better understand these diseases and engage, and
Your caregivers. The family caregivers.
It's easy to meet the metrics because we have a captive audience, but their IQs are under 70, so they probably don't understand what's being presented to them.
What about their family caregivers, though?
Their family caregiver, the direct care staff, they've got a good support staff of dietitians and podiatrists, and the outcomes for the diabetes are really good because we do have a captive audience, and it's 24/7, and
Yeah.
we're able to maintain it. We've only got a couple that kind of are outliers, but for the most part, they're in control.
That's great.
But, so that's kind of where we struggle, how does that patient portal fit into that type of population?
But I like your thought. Behind every patient, there's usually a handful of family caregivers that are supporting that patient who might be more well-versed with technology and want to help
Yeah.
care from that perspective.
There would be some family.
I know I have control of my son's health record through my chart. It's very helpful and easy to kind of get what you need that way. So it's definitely,
That makes sense, just extend it out to the guardian.
yeah.
Yeah, well, and, in our state, in terms of, the CHIEF, Medicaid patients are automatically enrolled. So probably your dual eligible members of your community they're enrolled with the CHIEF, for example. Well, could someone in your setting have proxy access just to something that makes sense for them, or, communicate a subtlety of care change to their doc? You would need permission.
Guess we better start putting some stuff out that you.
Well, and I think with the status also, permission and privacy security can be a barrier. So you bring up an interesting place where it might make a difference for care. Can our systems adjust to allow that?
Is that what this MyG is? Sorry, I missed the presentation yesterday.
Yeah, I'll talk about it.
Any other questions? No? All right. Well, thank you so much. Yeah, it's a pleasure.